So Dutton says that Cervicogenic Headache Society defines a cervicogenic headache as pain perceived in any part of the head and caused by a primary nociceptive source of musculoskeletal tissues innervated by the cervical nerves. The condition is characterized as pain localized to the neck and occipital region that may project to the forehead, occipital region, temples, vertex, or ears. A person with cervicogenic headaches is usually has pain of moderate intensity, which begins in the neck or occipital region and spreads to the head. And then the pathology is that injuries to the upper cervical areas include muscles, joints, ligaments, and then the discs. For the pathomechanics, it's usually irritation of muscles innervated by the cranial nerves, compression of the C2 posterior root ganglia between the C1 posterior arch and the superior C2 articular processes, which you can see in this picture. It's also the compression of C2 anterior ramus at the articular process of C1 and C2, and then the entrapment of the C2 posterior root ganglia by the C1 and C2 epistrophic ligament. And then for the signs and symptoms, some signs and symptoms include dull aching pain from the neck to the head. Pain is aggravated by certain head movements or sustained neck posture and abnormal tenderness of neck muscles. And then for functional limitation, the cervical range of motion and a reduction in the strength of the cranioflexor muscles is something that you find with these headaches. Then for the tests and measures that you use, you can do neuroimaging, and with these, the X-ray, the MRI, and the CT scan, you must reveal at least one of the following: movement abnormalities during flexion and extension, abnormal posture, or fractures, bone tumors, rheumatoid arthritis, or congenital abnormalities. And then with the flexion rotation test, to perform this, is to determine upper cervical joint dysfunction, and it looks at C1 and C2 dysfunction. And it is performed by putting the patient in full flexion and then attempting to rotate the head from side to side. It is normal to get 40 to 44 degrees, but if it is less than that, then they could have a dysfunction in the C1 and C2 area. It is also important to check the cervical range of motion for this as well, because that could be limited. And then to perform the craniocervical flexion test, that's this picture down here. So you put the patient in supine, and their neck is in a neutral position with a pressure biofeedback unit placed under the neck. And then the patient is instructed to move the head vertically as if saying yes in a slow, controlled way. And then the movement causes the pressure in the biofeedback unit to increase. And it starts at 20 units of pressure, and for each time you do it, it increases by 2 millimeters of mercury of pressure. And then for each time you do it, you hold it for 10 seconds and then relax. And you do this up until 30 millimeters of mercury. And it's usually repeated twice. And then it is also important to palpate for trigger points.
You have differential diagnosis. Differential diagnosis of cervicogenic headaches includes migraines and tension type headaches. Just go over a few of the measurements for diagnostic measures. Pain lateralization. Cervicogenic headache pain is unilateral without side shifting, while migraine pain is 60% unilateral with side shifting, and tension headaches are bilateral and diffuse. The location of cervicogenic headaches is typically in the occipital to frontoparietal and orbital regions of the head, while migraines are frontal, periorbital, and temporal regions, and tension headaches are diffuse throughout. Pain quality, cervicogenic headache pain is not throbbing, it's not lancinating, and it's usually dull and aching starting in the neck, as we mentioned before. And migraine pain is throbbing and pulsating, while tension headache pain is also dull. Triggers for cervicogenic headache include cervical movement, poor posture, and pressure over the by neck movement, have multiple other triggers. The rehab process includes three phases: maximal, moderate, minimal protection phases. The goals for the maximal protection phase include reducing pain, performing very light pain-free passive range of motion of the cervical spine, isometric strengthening, as well as postural retraining. Exercises in this phase include self-mobilizations of the cervical spine, isometric holds, maybe using something like a band or a towel, and sitting and standing postural exercises. And keeping in mind in this phase, you have to limit active head movements, just doing passive movements the whole time. Moderate protection phase, the goals include to start strengthening neck flexors, start performing dynamic isometric exercises, start upper quarter strengthening, which also includes scapular strengthening and postural training, and also start muscle stretching exercises. In this phase include the cranio-cervical flexion exercise, and this phase is going to be done in supine. You also have the four-way dynamic cervical extension exercise, the upper trap and levator scap stretches, and upper quarter exercises such as shrugs, scap squeezes, chest flies, and reverse flies. And then we have the minimal protection phase. Goals in this phase include start sensory motor training, start incorporating functional activities associated with each patient, and start and continue endurance training. Exercises include progressive CCF exercises to a sitting position, start doing exercises on unstable surfaces to help reflexive and postural stabilization. Start doing functional exercises such as carrying a weight over an extended period of time, or doing overhead raises, and then progressing the upper quarter exercises by adding reps or longer holds at hand range. Likely outcomes: headache frequency reduction. PT is typically seen as the best long-lasting treatment to reducing cervicogenic headache frequency, pain, and duration. Strength of neck flexors. PT is going to help strengthen the neck flexors, the deep neck flexors specifically, with that CCF exercise, as well as four-way dynamic cervical extension exercise. And then postural re-education. Patients will show improved posture with exercise, as well as be educated on correct postural position and muscle coordination. Sensory motor training. PT will improve sensory motor deficits associated with cervicogenic headaches and progress the patient towards increased stability when performing ADLs. And that leads us into improved ability to perform ADLs. Patients will be able to perform ADLs without increase in headache frequency or pain, and they'll also learn how to perform ADLs without triggering headaches. And of course, all of these things will improve quality of life. And an overview of everything that we learned today. Condition and pathology, we learned that the pathology includes muscles, joints, ligaments, and or discs. Pathomechanics, we said that cervicogenic headaches can be caused by many things, such as irritation of muscles that are innervated by cervical or cranial nerves. Signs and symptoms, we know that CGH or cervicogenic headaches produce a dull aching pain that is aggravated by specific neck movements and sustained neck posture. Functional limitations. There's a few functional limitations, mostly associated with range of motion. Tested measures. A few of the tested measures we talked about today were flexion rotation test and the cranio-cervical flexion test. Differential diagnosis. We learned that the differential diagnosis includes migraines and tension type headaches. In the rehab process, the rehab protocol consists of treatments such as isometric strengthening, cervical mobilizations, neck muscle strengthening, postural exercises, sensory motor exercises, and functional exercises. And then we have the likely outcomes that we just went over.
These are our references.
Pathomechanics. So you got irritation of muscles innervated by the cranial nerves, compression of C2 posterior root ganglia, compression of C2 anterior ramus, and also C2 posterior root ganglion is entrapped. Now, they've given you the pathomechanics, right? Now, what typically brings about the pathomechanics is actually position, movement. So a culprit for this pathomechanic, who can guess what the culprit is most of the time? Forehead posture, all right? So forehead posture is often the culprit of these pathomechanics. So with the forehead posture, you know when structure dictates function, function dictates structure. So when you have a malalignment of structure, then certain things are gonna create unwarranted tension and pulling and stress on certain structures. So that's what the forehead posture does to these structures. With the forehead posture, right? SCS, this is subcranial spine. What position do you think it puts the subcranial spine in? So it puts the subcranial spine in a backwards bent position. It puts it in backwards bend. It puts the subcranial spine into extension, right? It puts the mid-cervical spine. What do you think it does with the mid-cervical spine? It puts it to forward bending, or you can say flexion. Backwards bending, you can also say extension, right? So that is what it does to the cervical spine. So the subcranial spine goes into a backwards bent position. The mid-cervical spine goes into a forward bent position. So in turn, what happens? So we see these X's on the sternocleidomastoid muscle. So if the mid-cervical spine is going into forward bending and flexion, what is happening to the sternocleidomastoid muscles as they act together? They flex the cervical spine. So when I act together, they flex the cervical spine. When I rotate to the right, the left SCS is contracting right. When I rotate to the left, the right SCS is contracting right, concentrically. So, but when they act together, they forward bend. So what happens is, I'm gonna put a little bullet up under here, right? The SCMs, they become taut. They become taut, or I can say shortened. And that can cause a problem. What nerve innervates the SCM? Spinal accessory, right? Innervates the SCM and what else? Upper trapezius, okay? So now that can cause a problem. So now we got SCM being a problem. We got all of these structures being stressed in an unwanted way. Now, an unwarranted way, if we talk about backwards bending, now this is content you need to know, that's why I'm taking my time going through this, you can see this. So with backwards bending, I didn't leave myself to write a bullet under here. But with backwards bending of the subcranial spine, what happens to the suboccipital muscles? They become shortened, right? They become taut and shortened as well. So you got suboccipital muscles are taut. That's a problem. The deep neck flexors, I'm gonna write 3. Who can guess what happens with the deep neck flexors? They become elongated. Now, so what ultimately happens, we have to correct muscle imbalances. So we have to work on the extensibility and the suboccipital muscles. And so we have to work on the extensibility of those muscles and also strengthening them eccentrically as well. We have to work on the extensibility of the SCMs, sternocleidomastoid muscles, and strengthening them eccentrically as well. Then we have to work on strengthening the deep neck flexors concentrically because they're going to be elongated, so they're most likely going to be weak concentrically. So that's when we focus on those, and that's when you can implement the go back to one of your slides where you're talking about the pressure, that one right there. You can actually implement, the cranial, what were y'all talking about? The biofeedback, this is where you can implement the biofeedback as intervention as well, okay? To strengthen those deep neck flexors. Why would it be so significant to know what the forward head posture results in? Because you're gonna see patients with it. In fact, people are living longer. You're gonna be working with the geriatric population. You're gonna be working with people who have sitting jobs, who sit at a computer all day long, and they develop that forward head posture. Believe me, you're gonna see it. So you need to know this like a must know for physical therapists, the adverse effects of the forward head posture. Because now, when you see a patient with forward head posture, really you already know what's going on before you even do the assessment. When they come with a forward head posture, you already know what you have to deal with, and what you have to treat, okay?